Good afternoon. My name is Nathan Brazier, and I'm reporting on my study, Effective Management of Medial Tibial Stress Syndrome in the Secondary School Cross Country and Track Athlete. The first group of slides provide a quick overview from the abstract. As any athletic trainer knows, secondary school runners frequently suffer from shin splints, which more properly should be called medial tibial stress syndrome, or MTSS. Participants were actually cross-country and track runners at the Oakland Athletic Association high schools in an academic year of 2015-2016. The study examined alternative treatments and found, with an analysis of variance, that intervention did produce a significant shorter recovery time than no treatment. It also found that there were no significant differences in recovery time among the three interventions or between the two sexes. Now, starting from the beginning, the motivation for this effort was the desire to have more clarity in determining how to treat medial tibial stress syndrome in high school runners. MTSS, or medial tibial stress syndrome, affects a significant percentage of high school runners. In fact, ATR and Morin reported that between 4 and 35% of athletes and other active individuals will report having symptoms consistent with MTSS. In 1968, the American Medical Association defined shin splints as pain and discomfort in the leg from repetitive training on hard surfaces or forcible extensive use of flexors. It is important to note that this pain below the knee and above the ankle along the tibia, more formally called MTSS, can occur in the anterior, medial, or posterior aspects. Korsch et al. Reported that jumping athletes present more with MTSS pain associated with the anterior middle third of the tibia, while runners tended to have a more posterior medial tibial pain. One theory, and a popular one, for the causes of MTSS is the shin pain results from an overuse injury to the tibia that is from a stress reaction involving the bone periosteum and tendon. Risk factors for MTSS include proper foot mechanics, footwear, lack of athletes' physical conditioning, and of note, female athletes appear to have more frequent incidents of MTSS than their male counterparts. It was also found that athletes that have a higher BMI also has a higher incident rate of MTSS. This study sought to address three problems we found in applying prior studies. The first is that the prior studies were all done with an older student athlete population in the range more consistent with college age or older, or they were done with military personnel that are also in that older age bracket. It seems wise to verify that the results of prior studies did indeed apply to high school athletic runners. Prior studies also did not use a control group. They only compared interventions and made no comparison to a control with no intervention, only rest. Finally, prior studies used achievement of a specified pain level rather than return to full competition as the measure of completion and recovery. It is not clear that these two measures are equivalent or that the achievement of the pain level in itself results in return to full competition, a measure that is more meaningful if perhaps less precise. The purpose of this study was to determine the most effective interventions used to reduce the effects of medial tibial stress syndrome, or MTSS, in the male and female high school cross-country and track student athletes. The research question: what were the most effective interventions to reduce the effects of MTSS in male and female high school and cross-country track student athletes? The null hypothesis was that there was no significant difference among the interventions to reduce the effects of MTSS in male and female uh, cross-country and track student athletes. The study design that we used was a mixed methods quasi-experimental longitudinal design using randomized groups and a control group. To get a large enough sample, we had to go for an entire academic year, including both the cross-country and track seasons in the school year of 2015-2016. Thus, the study had to be longitudinal. The introduction of a strong control, namely no intervention, only rest, is a significant feature of this study. Participants in the study were student athletes at a Oakland Athletic Association high school aged 14 to 18 on the varsity or junior varsity cross country and track teams. Of those 300 students, athletes, only 20% actually presented with MTSS symptoms. These 60 athletes were placed in treatment groups randomly and was the basis for our comparison of treatments. All 300 student athletes submitted a detailed medical history, including a symptom checklist questionnaire at the beginning of their season. These instruments helped us to avoid inclusion of athletes with conditions that would confound diagnosis and interpretation of our sample. 60 runners who experienced MTSS were randomly placed in one of three treatment groups or control group, which received no treatment other than an inspection by the athletic trainer. The data was analyzed using ANOVA, and all the analysis of variances were performed at a significant level of 0.5. Average time for treated runners to recover was significantly less, with 30 days, compared to runners in the control group who received no treatment and took 37 days to go full return. There was no significant difference found among time to recover for the three treatment groups, nor was there uh, any significant difference between time of recovery between boys and girls. To date, this is the first mixed measure longitudinal quasi-experimental randomized control group study that has evaluated the effects of MTSS treatment, comparing a control group on the days it took from injury to return to play in cross country and track, to my knowledge. The study results agreed with prior studies on the fact that older students in the finding had no significant differences among interventions and no differences between the sexes in response to intervention. The study did differ from previous studies in the finding that a significant difference between control of rest, no treatment, and interventions, 37 days versus 31 days to re-entry into return to play. This is a new finding in part because previous studies only compared treatments and did not have a true control of no treatment but rest. It is my belief a study should be uh, done measuring recovery at reentry to competition and a pain-based recovery time protocol using the same athletes so that the relationship between the two can be determined directly. I also believe that the use of a no treatment other than rest control should be strongly considered in the future designs of studies in MTSS. Such a control would have greatly clarified the meaning of many of the studies in the literature. Similarly, a study should be performed to evaluate pre-injury interventions that Similarly, a study should be performed to evaluate pre-injury interventions to avoid the incidence of MTSS in secondary school athletes, specifically cross-country and track. We found no such study in the literature. Athletic trainers working at the secondary school level should feel comfortable intervening with athletes of MTSS because the studies showed that the interventions are more effective than doing nothing. We should also be choosing our interventions most appropriate for the injury and the runner because, again, the study showed no difference among. An athletic trainer working at the high school working with secondary school runners should feel comfortable intervening um, with interventions because the study has shown that this is more effective than doing nothing. It also has shown that the interventions should be most appropriate for the injury and the runner, and the use of the same interventions regardless of sex, because there was again no differentiation between length of time um, from recovery or from injury to recovery in any of the three groups. In summary, MTSS is an injury that affects many runners and active individuals. Um, the study measured effectiveness of total time to return to completion and included a control of no treatment other than rest. It showed intervention is more effective than doing nothing. It did not show that any one intervention significantly was better than any of the others. It also did not show any difference between men and women in response to these interventions. These findings have a direct application to selecting appropriate responses to the athlete when presented with MTSS.